Carcinoembryonic Antigen, CEA, Insights for the Clinician, the Science, Clinical Importance, and Monitoring After Tumor Resection. Welcome to today's episode, where we dive deep into the world of tumor markers, specifically, carcinoembryonic antigen, or CEA. If you're a clinician, a student, or simply someone interested in the science behind cancer diagnostics, you'll find this discussion both thorough and practical. Let's explore CEA's role, significance, and what happens after a tumor is removed. Overview: Carcinoembryonic antigen, or CEA, is a glycoprotein that plays a part in cell adhesion. While it's prominent during fetal development, its presence in healthy adults is minimal. This marker has become especially important in oncology, particularly for colorectal cancer surveillance. Biological role: let's start with CEA's normal function. During fetal life, CEA is produced in the gut, pancreas, and liver, but after birth, its levels drop significantly. In adults, only trace amounts remain, typically less than 2.5 to 5 nanograms per milliliter, because of natural turnover in the gastrointestinal tract. Now, why do we care about CEA in cancer? It's overproduced in several adenocarcinomas. Think colorectal, pancreatic, gastric, lung, and breast cancers. In clinical practice, we primarily use CEA to monitor treatment response and detect recurrence, rather than for initial diagnosis. Clinical uses: CEA has several important clinical applications. Prognostic indicator: elevated preoperative CEA often means more advanced disease and correlates with poorer survival. Treatment monitoring: if CEA levels drop after therapy, that's a good sign. Rising levels can suggest residual disease or the possibility of metastasis. Surveillance: monitoring CEA helps spot recurrence after tumor removal, especially in colorectal cancer. CEA half-life: here's what you should know. CEA's half-life in the bloodstream is generally about 2 to 8 days, averaging around 3 to 5 days. This can vary depending on liver function, since CEA is cleared by the liver, and on tumor burden. Higher levels may clear more slowly. Post-resection dynamics: what should we expect after curative tumor resection? After successful removal, CEA should have every 3 to 5 days. For most patients, CEA returns to normal within 4 to 6 weeks, depending on the starting level. If the CEA level fails to normalize, it may suggest residual tumor tissue. A rebound in CEA after normalization could indicate recurrence or metastasis. Let's take an example. If a patient's pre-op CEA is 100 nml, you'd expect it to drop to roughly 50 nml in 3 to 5 days, 25 nml in 6 to 10 days, and so forth. Limitations: of course, CEA isn't a perfect marker. False positives: conditions like smoking, inflammatory bowel disease, pancreatitis, and cirrhosis can also raise CEA, though typically not above 10 nml. False negatives: some cancers, such as MSI-high colorectal cancers, may not secrete CEA at all. Key takeaways to wrap up today's discussion: CEA's half-life is about 3 to 5 days, so always look at trends, not just single values. Following tumor resection, CEA should normalize within 4 to 6 weeks. If not, further investigation is warranted. CEA is most useful for surveillance after colorectal cancer treatment, not for primary screening. Thank you for joining us for this clinical overview of CEA. For more insights and deep dives, don't forget to subscribe and tune into our next podcast.